Welcome to the St Emlyn's podcast. I'm Ian Beardsall. And before we dive into today's episode, all about shock, recorded at Trauma 2030, I just wanted to thank all of you who've downloaded MedPod Learn and are giving it a go for your medical podcast listening. I'm so grateful to those of you who got in touch and said the things you like and also suggested some improvements. I'm delighted to say upgrades are coming. This will include the ability to play podcasts at different speeds, up to 2 times faster than normal speed, as well as being able to be more specific about your activity download, so you can limit the download for exactly what you need for your CPD and appraisal purposes. If you haven't discovered it yet, it's available on App Store for both Google and Apple, and it's free to download. You can try it for a month, all the extra learning tools, without paying a penny, or just download it and use it as a medical podcast library. Give it a go and see what you think. And as ever, if there's things you'd like me to try and add to it or change, just get in touch. It's almost incrementum in Mercia, and part of the excitement for that is thinking about who's going to be talking and who we're going to see there. And Simon and I are delighted to be going again. If you are there, then please do come up and say hello. It's always lovely to meet people who listen to the podcast. And to whet your appetite, I have added to the recommended listening on MedPod Learn some episodes from both St Emlyn's and other podcasts featuring speakers who will be in Mercia on stage speaking next week. For now, let's get on with today's episode. Welcome to the St Emlyn's podcast. I'm Ian Beardsall and I'm at Trauma 2030, and I've managed to grab Rich Carden, an old friend from St Emlyn's who has gone on to great things with a PhD, which I'm sure we're going to mention, and working in London doing intensive care. He was an emergency physician. He was one of us, but has passed over to not the dark side, probably the side with all the lights and the beeps. But Rich, without me saying too much, why don't you introduce yourself to our listeners?
Thanks, Ian. I'm Rich. I'm an intensive care trainee, subspecialised in neurointensive care, who's previously done a PhD in trauma sciences, which is why I'm here today.
And you did a talk this morning about shock. Now, shock is one of those subjects that I absolutely love teaching about. I'm slightly anxious that over the next 10 minutes, you're going to tell me that everything I've taught a couple of generations of medical students is wrong, but we'll see. Let's start with what shock means, shall we? And I think sometimes we forget what this means. What would shock mean to you, Rich, as somebody who's done a PhD that involves that very word?
So I think the unifying thing that we all have to remember with shock is that it has to involve some sort of definition around inadequate delivery and utilisation of oxygen. So that's at its most basic level. We all are aware of the different etiologies that lead to that physiological state. But for me, it can be a wide differential as to why you end up in this position where you're no longer able to either deliver or use oxygen at a cellular level.
So we've got this idea that shock is about oxygenation in cells. We often use blood pressure as a surrogate. Is that a fair thing to do?
It's not an unreasonable thing to do. Perfusion is hard to measure. Blood pressure is easy to measure. And if we think about the history of our understanding of shock, it's only a short history, relatively. Our body has evolved to deal with injuries for thousands of years, but it's only in the last 300 years or so that we've started to try and understand what happens following injury. There was a French surgeon called Ledran, who 300 years ago was the first guy who wrote about shock in a paper, and he used that to describe this state of pallor, weak pulses, cool peripheries. And then that was the very first sort of introduction to what shock is in the literature. And that's been expanded upon over the last 300 years. And the sort of seminal works of George Cryle, who's an American surgeon who was the first to measure blood pressure during operations and found that a blood pressure below 90 was associated with worse outcomes. What's important about that is that he set that as a physiological threshold and not a definition. And then following on from Cryle, there's Carden in the First World War, Blaylock, Wiggers, and these researchers expanded upon this idea of blood pressure and of these clinical signs that Ledran described to integrate the idea of hypoperfusion, metabolic failure, homeostatic failure, becoming acidotic. And then we have led to the sort of 50 years ago, Weil and Shubin came up with this idea of classifying shock based on an etiology, so the obstructive, cardiogenic, distributive, and hypovolemic etiologies. And then that's led us to understand that actually the etiologies are diverse, but the fundamental unifying element is this failure to deliver oxygen. So to answer your question about flow versus pressure is very easy to measure. We have either invasive arterial lines, or we can use non-invasive blood pressure measurements. We can measure pressure very well. Perfusion is much harder to measure.
And when we measure that blood pressure,
Worth remembering that blood pressure is equal to heart rate times stroke volume times total peripheral resistance. And we can look at maybe each of those components, and there's little bits within those where you can break it down even further. Is it reasonable to go back to the physiology when we're thinking about the treatments that we're going to give?
I think so. I think ultimately our goal is to deliver oxygen to the mitochondria. And a lot of the sort of pathophysiology that we see is because cells are starved of oxygen through a different, whichever mechanism. So fundamentally, at a cellular level, the mitochondria aren't getting oxygen. They send out distress signals. Those distress signals increase things like local vascular permeability. They cause changes in the vascular endothelium. They cause release of antithrombotic proteins that improve blood flow through those tissues. So the body's incredibly intelligent in that there are lots of response mechanisms to absent oxygen. But what happens in major trauma is that you have a whole body response. So there's no communication between the cells, and they're all equally starved of oxygen and all equally trying to exploit their environment to get more, which leads to things like cardiogenic shock, which leads to things like vascular permeability and distributive shock. So these are all just maladaptive processes that our bodies evolved to do to restore perfusion and oxygen delivery at a local level.
When I'm at a dinner party, which doesn't happen often, I don't get many invites, but if I am there and when people ask me what I do, I joke about saying that my job is to facilitate the manufacture of ATP. And I kind of see that as what we do in resuscitation with an ABC type thing. Airway, breathing, circulation is just about getting oxygen to mitochondria, as you describe. It's that simple and that straightforward. But it's fascinating what you say about trauma, particularly where that is a whole body response. That's not just the lungs responding to needing more oxygen because they've got infection, or the heart responding because it's got occlusion. This is the whole thing is exploding. Does that differ the way that we're then going to look at treating the shocked major trauma patient?
Possibly. I think the important thing is that our patients are on a timeline. So you may start off with haemorrhagic shock where you've bled, you've lost volume, you've lost plasma proteins, you've lost your HB delivering capacity, and you're bleeding. And we can fix that. We can apply DCR principles. We can have surgical control of bleeding. We can give blood transfusion, restore volume. However, patients are still shocked, and it's not hemorrhagic. Hemorrhage is stopped. Something else is now taking over. And it's trying to understand these switches between the different etiologies of shock that occur during that patient timeline.
At its most simple level, I would say that we've got a bleeding patient, they're in hemorrhagic shock, let's treat the hemorrhage. But it's a lot more complex than that, because actually that hemorrhagic shock, once you've managed the hemorrhage, becomes a different type of shock. Because now we're going into perhaps tissue ischemia, or there's reperfusion that's causing all those metabolites that are affecting the organ. And that's where that cardiogenic shock comes in. Are there things that we need to think about in the early parts of resuscitation, apart from the simple, straightforward stuff we talked about, to try and minimize that cardiac dysfunction later down the line?
So this is where I think what we do is probably good. Ultimately, avoiding shock is the only way to prevent further shock. So there is this idea of shock tolerance and a dose of shock. Some people are more tolerant of ischemia for longer periods of time than others. You can't predict that, and you don't know who that is at the moment. But what we want to do is minimize the dose of shock, so the magnitude and duration of shock that someone is exposed to. And that is where all our sort of trauma principles come in, because we're trying to decrease that duration of shock and decrease the intensity of shock. And we do that through stopping the bleeding, providing blood products, trying to restore the vascular cohesion and integrity. We're trying to correct coagulopathy, correct hypothermia, correct our metabolic derangements. And these are all focused at trying to minimize shock ultimately. What we can't do much about is ischemia reperfusion. And it's likely a lot of what we're talking about here is a global ischemia reperfusion type injury, which is what we see in out of hospital cardiac arrest patients who have this post-resuscitation syndrome, where they have myocardial dysfunction, hypoxic ischemic encephalopathy, and reduced conscious level. And we see the same, but we don't call it the same because we don't study it in trauma.
Bearing all of that in mind, we think about the simple, straightforward way to manage shock. And I think I've got a relatively okay system, I think, to work out which type of shock needs which type of treatment. But now it's really made me think about, this is not a one-off thing in the resus room. This is actually something that we need to be looking at 4 hours post-injury, 8 hours post-injury, 2 days post-injury. And this could actually happen further down the line. Is that a reasonable thing to say?
I think so, because in my mind, this is probably an oversimplified and a non-evidence-based timeline, but a patient will potentially go through haemorrhagic shock, inflammatory SIRS type syndrome, which can absolutely cause a shock. They may end up becoming septic because their immune system is weakened through being activated and deactivated during that in injury phase. So there's an inflammatory, septic, obstructive, cardiogenic, all these different types of shock are interplaying, and they will present at different parts of the patient journey. So I think it's really important to be open to these differentials and to start looking for them as early as you can. So integrating early echoes into your clinical assessment is probably quite useful, certainly from the cardiogenic shock kind of piece. Being able to do regular and early echoes is probably a good thing to do. Trying to understand the relative contribution of things like vasoplegia is much, much harder. And we don't have good ways of doing that at the moment. And we think about vascular injury and endothelial dysfunction, but it's actually in reality very hard to identify.
I think you alluded to the fact it's quite hard to predict who's going to have these sequelae further down the line. Is it difficult, or can you say that if you're young, physiologically fit, and otherwise well, you're less likely to have this problem? Or is it just impossible to predict?
It's possibly impossible to predict. I've done some work trying to identify these sorts of patients during my PhD work, and it was challenging in the sense that we don't have good ways of defining what the problem is. So we don't know what cardiovascular dysfunction and trauma genuinely is. We can go off some routinely collected data like SOFA scores, which is the sequential organ failure assessment score, and that's broken down into 6 domains. One of those is a cardiovascular domain. If you score maximally in that domain, it's a relatively, I would consider, moderate dose of vasopressors that tips you over into being failure in that category. So even our definitions that allow us to identify a failure are probably inadequate. So actually understanding the problem is much, much more complicated than I'm making out. That being said, with that piece of work, those patients who did end up developing cardiovascular dysfunction, and I'm cautious to use the word old because I fit the category now and I don't consider myself old, but they were older. There was more blunt mechanism of injury. They had higher injury severity scores, higher markers of, or worse markers of shock, so lactate, base deficit, blood pressure was lower, etc. And the majority of them activated the major hemorrhage protocol, which is all obvious, right? So we're saying the sicker you are, the more likely you are to be shocked for longer, which is what it comes down to, which is very straightforward and intuitive, I would imagine. So think about your more severely injured patients who activate code red. They're the ones who are at risk of persistent shock and different etiologies.
Bearing in mind that shock can be caused by lots of different effects on the equation we talked about, I've always thought that if you're bleeding, I just give you blood and I don't give you pressors and I don't give you other things to maintain your blood pressure. I stop the bleeding, give you blood. But I'm thinking more and more that actually we need a multifactorial approach, and my blunt approach to this probably is a bit too simplistic. Does your work mean that actually we should try and make sure we're maintaining flow and oxygenation of tissues? And if that means we need more than one modality, so we need blood and we need pressors, is that the way forward, or can we stick with a simple way I've been doing it?
Well, I think the debate about pressors early in trauma, there is a debate. Some people have different opinions and different parts of the world have different practices. I guess the UK consensus practice would normally be to avoid pressors until your volume replete and you've stopped the bleeding. And I think that is borne out in the literature where catecholamines, vasopressors are directly harmful to your peripheral vasculature and the endothelium and the glycocalyx, but it's directly harmful to the peripheral vasculature. So you may be improving a number by using a pressor, but overall you're going to commit that patient to worse outcomes over the next few days down the line. You think you're improving stuff by having a better blood pressure when actually you're worsening the macro circulation and the micro circulation coupling. You're going to exacerbate vasoconstriction that's already happened. You're going to cause more small tissue ischemia that you can't quantify. We're not talking about ischemic liver. We're talking about ischemic capillary beds. You can't quantify that. You can't see that. You are absolutely going to cause that by using pressors on an empty system.
And go on, you've said the word. I still don't really think I understand it, but it seems important because people keep saying it. Can you give me a beginner's guide to the glycocalyx?
I don't know if I can, but I'll try. The glycocalyx is basically a furry gel-like substance that lines different endothelia, but particularly relevant is the vascular endothelium. And it is a form of protective barrier that stops all those endothelial proteins being exposed to the circulation. It's a dynamic structure that can change. In shock states, it gets shed. So the cells drop this glycocalyx layer, and you can pick it up on biomarkers like syndecan-1 is one that's very sensitive for glycocalyx. But what that means is that then you've lost this protective barrier, and then the vascular endothelium has lots of things on its cell surface that aren't meant to be in contact with the blood. So you get prothrombotic and antifibrotic substances being activated at the same time. So you're just creating chaos in the local blood supply, where you get microthrombi formation, you get reduction in your gap junctions between the endothelial cells, you get leaky blood vessels and increased vascular permeability. So it's detrimental. We assume it's detrimental. There may at some point have been a evolutionary benefit to doing this at a local level, but when it occurs systemically, that's when we end up with this horrible vasoplegia, distributive shock type picture. It's often a big driver of that is the loss of that glycocalyx protective effect.
All the work you've done has turned what is something that I hope is moderately simple, which is getting oxygen into cells, into something that's physiologically fascinating. And I'm going to ask you for an impossible thing now. You spent years doing a PhD looking at all of these things. What would be the top take-home message you would take from that PhD that would be applicable to somebody like me working in an emergency department or an intensive care unit?
I would argue that doing the standard sort of package of care that we have for trauma patients exceptionally well every single time and as early as you can is the fundamental thing that we can do at the moment with our current state of medical technology and treatment. Is the best thing that we can do to prevent the deleterious effects of shock. So thinking about our standard damage control resuscitation, stopping the hemorrhage, giving an appropriate blood transfusion. I say appropriate because that in itself is a minefield that I probably can't go into in enough depth, and I'm not expert enough to know about which blood products are the best blood products, but an appropriate transfusion. We don't even know how much patients need. That is a really hard thing to get right. Knowing how much blood a patient requires, when a patient requires blood, they are still very difficult things to know. And each time we give a blood product, that's an inflammatory hit that we need to consider as well. So an appropriate transfusion, minimize bleeding, stop the hemorrhage, use our tranexamic acid nice and early, minimizing hypothermia, correcting coagulopathy, correcting metabolic derangement. And then I would argue that we should start thinking towards perfusion and not just pressure. And once we put that package together as early as we can, that's likely going to be the thing that we have available at the moment that will give the best outcome.
Rich, it's absolutely fabulous to see you, and listening to you is inspiring to try and remember some of that physiology, which is genuinely, I believe, the rock on which we should build all the stuff we're doing. Thank you so much for your time. I know that you've got a nativity service that you need to get to, and I can't keep you from a crowd of 3-year-olds singing carols. So thank you so much again, and it's lovely to see you.
Thanks, Ian.